Good afternoon, everyone. I'm Melissa Hanson, a program principal with the National Conference of State Legislatures Health Program. And on behalf of NCSL, I would like to welcome all of you to today's webinar, Integrating Behavioral and Primary Health. Before we get started with today's panel, I would like to remind participants that NCSL is a bipartisan membership organization of state legislatures. NCSL advocates for the interests of states and provides policymakers the opportunity to exchange ideas. This webinar is one such platform for information exchange. We encourage a robust Q&A at the conclusion of the presentations and remind listeners that opinions expressed on today's webinar do not represent NCSL's policy positions. Also, today's webinar will be available on NCSL's website as an audio archive. Before I introduce today's fantastic panel of speakers, I want to thank both the Commonwealth Fund and the Health Resources and Services Administration for their support of today's webinar. Over the last 3 legislative sessions, NCSL has increasingly heard from policymakers investigating innovative ways to improve the efficiency of their state's behavioral health and primary care systems, with an eye to integration because it seems to make sense. Many Americans with physical health conditions also have behavioral health conditions. Further, the research consistently finds that collaborative care to be more efficient than the current model, which is fragmented. In fact, the Institute of Medicine concluded that the separation of primary health and behavioral health was leading to inferior care, and they came to this conclusion almost 20 years ago. Legislators are also interested in integration because of the growing evidence that integration can contain costs in health care. Spending for patients with mental health or substance abuse problems is 2 to 3.5 times higher than those for without a behavioral health issues. The theory is if you can address the behavioral health concerns, compliance with treatment and self-management of chronic and other conditions will increase, as a vast majority of treatment dollars for these patients with comorbidities is going towards general medical services, not behavioral health services. Many states are also dealing with a shortage of behavioral health providers. In order to adequately meet the behavioral health needs, especially in the area of initial screenings, the health systems might be required to leverage their primary care in new ways. Failure to recognize and appropriately treat behavioral health conditions affects health outcomes. However, integration is not a simple task. Until recently, there has been little financial incentives for health systems to integrate care. Primary care practices that seek to enhance behavioral health services face restrictions on the type of services that they could bill for, and reimbursement rates were often low. Coupled with pre-approval requirements in some systems, makes integration really hard work for providers. Some payers also use separate provider networks, billing, and coding practices for behavioral and primary care, adding additional administrative burdens to integration. Another challenge facing state efforts to integrate is the unique cultures of both primary care and behavioral health. Integration requires providers to adjust their practice methods. However, these challenges are not stopping states, including state Medicaid programs, from exploring innovative integration models. However, according to research supported by the Commonwealth Fund, many of these initiatives rely on grants, self-funding, or demonstration projects in Medicaid and Medicare, and are not yet standard business practices. For more information on efforts in Medicaid to integrate care, NCSL has included links to resources, including the Commonwealth paper, State Strategies for Integrating Physical and Behavioral Health Services in a Changing Medicaid Environment, on our website. As our panelists will address today, payment and delivery system reforms offer unique opportunities to integrate behavioral and primary health care. Now I have the great privilege of introducing our 2 panelists today. We are very fortunate to have Dr. Miriam Komari as our first speaker. Dr. Komari is an associate professor of medicine at UNM and associate director of the ECHO Institute. She is a medical director for integrated addiction and at the Tele-ECHO Clinic. aimed at engaging and supporting primary care medical clinicians in treating addiction and mental health disorders. She is the medical director for ECHO Care program to treat patients with complex medical and mental health needs and oversees the ECHO Access program, designed to expand access to behavioral health and addiction treatment in the primary care setting. Until 2012, Dr. Comaria served as the medical director for Turquoise Lodge Hospital, an addiction treatment hospital funded by the state of New Mexico. She is a board certified in addiction medicine and in internal medicine. She was trained at the University of California in San Francisco, where she was also an RWJ clinical scholar in the joint UCSF and Stanford program, and also served as faculty for a number of years. She is also the board chairman for the New Mexico nonprofit organization Healing Addiction in Our Community. Next, we will hear from Dr. Sarah Chenard. Dr. Chenard is the medical director of community care of West Virginia. She has an undergraduate degree in neurobiology from the University of Vermont and conducted scientific research at the University of California, Santa Barbara. Research in biomedical health services piqued Dr. Chenard's interest in medicine. She is a graduate of the Marshall University School of Medicine in West Virginia and serves as chief resident in the Department of Family and Community Health. Since 2003, in addition to serving as the medical director of Community Cares of West Virginia, a federally qualified health center, she has served as the chief clinical advisor for the Community Health Network of West Virginia. In recognition of her efforts, Dr. Chenard now serves as an advisor to the West Virginia Health Improvement Institute on health systems transformation and pay-for-performance initiative. She is also the co-founder of the Fayetteville Skate Park, a multifaceted recreational facility that's promoting physical activity and wellness. Before I turn the floor over to Dr. Komarami, I would like to remind the audience that the webinar today will conclude with a question and answer session. Please note you will not be identified when you ask a question, nor can other participants see what you have typed. As a reminder, you may participate by clicking in the Q&A button at the bottom right corner of your screen and typing your question. We will have plenty of time left for Q&A at the end of the session, so we encourage you to ask questions. Also, the PowerPoint presentation is available to you now and will be available later on NCSL website with the audio archive of this webinar. This archive will be ready in 5 to 10 business days. I would now like to turn the floor over to Miriam. Thank you.
Great. Thank you so much, Melissa. So I'm going to start out by describing the ECHO model, and then I'll describe some ways that the ECHO model can be used to expand access to mental health and addiction treatment services, and also a project in which we've applied the ECHO model to care for complex high utilizer patients who typically have combinations of medical and mental health problems. Project ECHO was founded 11 years ago at the University of New Mexico by Dr. Sanjeev Arora, who you can see in the large picture on the screen. He's a gastroenterologist who was treating patients with hepatitis C here at the University of New Mexico in the center of the state of New Mexico. But New Mexico is a large rural state, and he was one of the only physicians who was treating hepatitis C for low-income patients at that time. So many patients were having to travel several hundred miles a week to reach his clinic. There was a waiting list of over 6 months, and there were patients who were dying while they were on the waiting list. So he developed a model to try to expand access to treatment for complex, common medical conditions. He knew he was never going to be able to convince enough specialists to move to rural communities in New Mexico. And so instead, he developed a model by which specialists in the center of a region can connect simultaneously by video with multiple primary care teams around a state or region. They then have case-based discussions in which the PCPs present cases of a particular condition that's the focus of the clinic, in this case hepatitis C, and they receive mentorship and case-based feedback on co-management of the condition with the specialist. In addition to a medical specialist, there's usually at least one mental health specialist and often a pharmacist as well in the room. What you're seeing on this slide in the large picture is the group of specialists at the University of New Mexico, and they're connecting by video with primary care teams located around the state, who you can see in the smaller pictures. In a typical echo clinic, the presentation it's a 2-hour-long session at the same time every week. Primary care teams join by video from around the state. There's no cost for participation, and the primary care teams can receive free continuing medical education and CEU credits. An echo clinic typically starts with a brief didactic presentation by one of the specialists on a topic related to the disease of focus, and then goes into case presentations in which the primary care teams present patients and receive feedback and teaching from the specialists. Our mission at ECHO is to democratize medical knowledge and get best practice care to underserved people all over the world. And we have a goal of touching the lives of 1 billion people by 2025. This goal is a lofty goal, but the ECHO model is spreading very rapidly. These are communities around New Mexico that participate in ECHO, and each colored dot on there represents a different disease state, so that you can see that the community health centers and primary care providers in many of these regions participate in more than one ECHO clinic. ECHO has been replicated for many diseases here in New Mexico, including diabetes, childhood asthma, epilepsy, autism, cardiovascular risk reduction, pain control, etc. And the model is now spreading around the country. This is a somewhat outdated slide. There are now more than 47 academic medical centers around the country that are replicating the ECHO model. We also have a large collaboration with the Department of Defense and the VA, who are replicating ECHO for many disease states. In 2011, we published a study looking at outcomes of the ECHO model, and here we compared ECHO specialists with the primary care providers who are being supported by the ECHO model. So in the column labeled ECHO, you see results from the primary care providers who were treating hepatitis C with support from the ECHO specialists. And under the UNMH column, you see results for the specialists themselves providing direct care to patients. So you can see that the outcomes of cure for genotype 1, 2, and 3 for hepatitis C were the same for the specialists and for the primary care clinicians who were treating with guidance from Project ECHO. In addition, the primary care providers were able to reach a larger proportion of underserved minority patients in the rural communities compared with the specialists working at the university hospital. These data convinced us that this model was capable of training primary care providers to deliver care that is as safe and effective as the care delivered by specialists, with no greater rates of complication and actually improved access to care for traditionally underserved populations. The things that make ECHO work are that it focuses on team-based care, so we provide training not just to physicians, but also to physician assistants, nurse practitioners, counselors, pharmacists, community health workers, etc. And each of those groups works at the top of their game, so that a primary care provider is taking on some tasks that are traditionally taken on by a specialist, and other members of the team also are working at a very high level. ECHO serves to develop a community of practice and allows and promotes interprofessional consultation and guided practice. It allows for development of a mentor-mentee relationship. And ECHO itself, we treat as a movement rather than an organization. Everything that we do, all of our curricula and training to participate in our ECHO clinics are free of charge, because our goal is really to expand the use of this model to promote access to care. I'm going to focus for a couple of minutes on two innovative healthcare models that we've been focusing on using ECHO as the platform. These are conditions where there's a need for increased intensity of support and services for particular conditions. And so in these models, we have grant funding to actually hire or pay part of the salary support for the primary care teams that are delivering the care, and then we're supporting them through participation in the ECHO model. The first project that I'll describe is called ECHO Access, and it focuses on training primary care teams to care for mental health and addiction services in the primary care setting. The second project is ECHO Care, which is a team-based model supported by ECHO to care for complex high-utilizer patients. So ECHO Access, the mental health and addiction treatment program, is occurring in 5 primary care sites around the state of New Mexico. In each site, there's a small team consisting of a family nurse practitioner or a physician assistant, plus a community health worker. They focus their clinical work on screening, diagnosis, and treatment of mental health and addiction disorders, and their salaries are offset by funding from the General Electric Charitable Foundation. We started by bringing these teams together for 2 weeks of intensive face-to-face training, and then they returned to their primary care setting where they implemented broad screening for mental illness and addiction and began working with patients who screened positive or were referred to them in order to provide formal diagnostic assessment for mental illness and addictive disorders, as well as a treatment plan. The way that these teams are able to do this in a way that is safe and effective is through intensive support through Project ECHO. After the initial face-to-face training, each team participates in 4 hours a week of our weekly Integrated Addictions and Psychiatry tele-ECHO clinic. All teams present cases and receive case-based teaching and co-management support, as well as hearing didactic presentations every week. We know that adults learn best through practical, applied opportunities for learning. So the opportunity for learning when a team presents their own patient case and receives specific mentorship and feedback regarding management is really very great and typically exceeds the learning potential of a didactic presentation. So these are very rich conferences in which the teams are learning a great deal. The specialists who staff this clinic include specialists in addiction, psychiatry, counseling, community health workers who are behavioral health specialists, and also a psychiatric nurse practitioner. In addition to having access to this team through the ECHO clinic, the primary care teams can access members of the team via phone or email throughout the week. And our support team provides frequent site visits for mentorship, shadowing, and support. We think this is quite similar to a medical fellowship model in which when someone finishes an internal medicine residency training, for instance, if they want to become a cardiologist, they don't go to cardiology school. Instead, they start seeing patients who have cardiac problems, designing treatment plans, and then getting feedback from experienced cardiologists who are their mentors. And in this way, they do learn their trade through case-based learning. I already mentioned that the team is involved in developing fairly complex treatment plans, which include medication management, behavioral techniques, and referral to counseling when it's available in the local community. Also, this is a sophisticated form of triage, so patients with severe mental health problems can be efficiently referred to care from a psychiatrist when necessary. These are the 5 sites that have implemented this model around the state of New Mexico. The project has been going for 1.5 years now. We're evaluating the project by looking at the increases in numbers of patients served and mental health and addiction diagnoses treated. We're also surveying patients to assess changes in mental health and addiction-related symptoms, functional status, and social indicators such as the ability to care for one's children and avoid incarceration. We're also going to be using Medicaid claims to assess utilization of mental health referrals, emergency department, and hospitalization patterns, as well as total cost of care. Over time, the medical providers are becoming more and more efficient in their the provision of services so that they're able to use existing primary care codes and see a large number of patients during the course of a week. Their visits initially have taken longer than a standard PCP visit, but as they become more efficient, we're seeing that they're becoming financially self-sustaining. And 3 of our provider sites are reporting that the model is financially self-sustaining after 1 year. So this is both an effective and a cost-effective way of expanding access to mental health treatment services and diagnostic and prescribing services in a primary care environment for resource-constrained settings. Now I'm going to turn to a brief discussion of our ECHO Care project, which is another team-based model for providing intensive outpatient care for complex patients who are so-called superutilizers and are as you may know, this program is focused on Medicaid patients, and 5% of Medicaid patients eat up almost 60% of Medicaid dollars. So this is a very compelling problem to address, to figure out more efficient and effective ways of providing high-quality care for these complex patients at a lower cost. So the ECHO Care project targets patients who have been getting most of their care in the emergency department or inpatient setting. These are high-cost services, and these patients typically have little engagement with outpatient care. More than 85% have mental health or addiction problems, as well as severe and complex medical problems. A unique feature of this project is that we have collaboration with all of the New Mexico Medicaid managed care organizations. And collaboratively, the Medicaid MCOs are paying the salaries of these teams, and so are fully engaged partners in this experimental model. The intervention consists of 6 5-member teams around the state of New Mexico who provide intensive team-based multidisciplinary primary care that's able to address physical problems, mental health problems, and social issues for these patients. They see the patients not just in the office, but also in the home or, when necessary, in the community. And they receive intensive support through the ECHO Complex Care Clinic. This is a very collaborative model. We have a federal grant from the Center for Medicaid and Medicare Innovation and partnerships with the New Mexico State Medicaid Office, all of the Medicaid managed care organizations, numerous community health centers, and New York University for evaluation of claims data. So how does ECHO Care address the problems of superutilizer patients? The main way is through improving the primary care that's being received. The care is team-based and multidisciplinary and provides very coordinated, high-intensity care that integrates physical and mental health care and addresses social barriers. The teams also focus on transitions of care, and the teams are salaried rather than being paid fee-for-service. But the way that the teams are able to do this in a way that's efficient and high quality is through improved access to coordinated specialty care through the ECHO Complex Care Clinic. The Complex Care Clinic is somewhat different than what I described to you previously in the sense that here, instead of focusing on one disease state, the Complex Care Clinic has to address all kinds of complicated mental health and medical problems. So we bring together about a dozen specialists who are able to address a wide variety of illnesses and can provide integrated feedback to the teams on how to time the care that they deliver, prioritize the interventions that they're going to make, and work with patients to effectively promote behavior change with their patients in order to improve health. These teams, the primary care teams, are rather a remarkable bunch. We call them outpatient intensivist teams, and this is my concept of how these teams operate. They're pretty amazing. They consist typically of a nurse practitioner or PA, a counselor, an RN, and 2 community health workers, as well as having part-time administrative support. And they have to work in a very integrated, tightly knit way in order to provide care for these complicated patients. This is a picture of what you'd see in a complex care clinic where there are multiple specialists in the room interacting with the teams who are on the screen and are presenting their complex patients. The ECHO Complex Care Clinic allows for case-based learning with synchronized treatment recommendations from multidisciplinary specialists. As you all know, a lot of costs and complications of medical care come from duplicated services or poorly coordinated services, and also adverse outcomes of care if specialist A recommends a medication that may help their disease focus but worsen outcomes for another organ system or another specialty that's affecting that patient. This model allows resource sharing among teams and helps us to identify system barriers to care. The ECHO specialists also make themselves available to the teams for telephone consultations, so they're able to rapidly triage crisis situations. This is a schematic of the team. As I mentioned, nurse practitioner, RN, 2 community health workers, and a counselor, and they're backed up by the ECHO Complex Care Specialists. Evaluation is occurring based on surveys and focus groups of the patients, of the teams, and of the administrators of the clinics, as well as claims-based evaluation of utilization, cost, and quality. We have some preliminary outcomes of the ECHO Care intervention. After 9 months of enrollment in ECHO Care, Medicaid claims analyses show that the hospitalization rates have dropped to just 37% of the pre-enrollment rates as assessed over the preceding 12 months. Emergency department visit rates were only 45% of pre-enrollment rates, and costs have decreased by have decreased 40% and are now 60% of pre-enrollment rates. So costs have risen from about $3,000 per member per month down to $1,850 per member per month, falling an average of $1,200 per member per month. We're very excited about these outcomes, but they are clearly preliminary, and we're looking forward to our next round of claims data, which we should be receiving any day now. So take-home messages about this model for legislators and state government are that the ECHO model is an efficient way to leverage scarce healthcare resources and to expand capacity. Funding innovative programs based on this model can clearly provide targeted improvements in care to address specific problems, such as critical lack of access to mental health and addiction care, or the need to improve care and control costs for superutilizer complex patients. We do offer extensive training and support on the ECHO model through the ECHO Institute here at the University of New Mexico. You can contact me at this email address or go on our website to learn more about Project ECHO. And we're excited that some states are planning statewide implementation of the ECHO model, currently including Missouri, Colorado, and Vermont. Thank you very much. That's the end of my presentation.
Okay, well, thank you. This is Dr. Sarah Chenard. I'm the Chief Medical Officer of Community Care of West Virginia. And I was invited to participate to highlight some of the rural behavioral health care issues that we have in West Virginia. Just before we get started, just to kind of paint a picture, I know we have some West Virginia people on the phone, but for those of you from other states, we are in 9 counties in West Virginia, and we have 13 locations. We are all community health centers, and I have 50 medical providers that are some combination of either MDs, DOs, nurse practitioners, or physicians assistants. And not only do we have 13 outpatient clinics, but we also have just under 40 school-based health centers where we have a medical provider in the school delivering care to both the children and the teachers who are participating in our project. So one of the things that really comes up is what does this mean, integrated behavioral health? I understand that that was introduced in the beginning of the slide presentation, but I do think that one of the things that comes up is people are still associating behavioral health as really mental health, as something that is for people who have unique psychiatric diagnoses, and there is some lack of attention to the need for behavioral health for people who just simply have chronic conditions that need to be managed more intensively than what they're able to receive in their primary care setting. And I know that we discussed this in the last presentation, but I think that what I have highlighted in red here on the slide, the last bullet that says this care may address mental health and substance abuse conditions, but even more importantly, health behaviors, including their contribution to chronic medical illnesses, life stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. And that last one should resonate with most legislators, that we are moving into this era where, since we've had this SGR repeal, we're going to be paying a lot more attention to resource utilization, and Medicare has outlined a fairly rigorous program starting in 2019 officially, but backing up as soon as now, where we're gathering data so that we can see how do our physicians, and with an emphasis on primary care, how are we doing with healthcare quality, and are we paying attention to our resource utilization? That piece is going to become so important and is one of the largest barriers in our rural setting, because what we find is even if we put in good programs, we often have trouble then with referring, with specialty care, and with being able to reach people. And something like Project ECHO that was just described would be a great fit for a state like ours, where there's almost a hesitation on the part of our providers to do too much screening, because then when these problems are identified, it seems that there's a bottleneck in then accessing complete care. So that's sort of issue number one in and around healthcare utilization. But then also focusing back on this need for integrating behavioral health for chronic health conditions. I have a few other statistics later, but I was looking this morning, and West Virginia, it's sort of a moving target, and as of last year, West Virginia overall was ranked 44th in overall health. And our biggest challenges are, number one, our high prevalence of smoking. Number two, our high rate of drug-related deaths, and I'll get into that in just a minute. And then number three, our high prevalence of obesity. So if you take the first and the third there, smoking and obesity, both of those are intimately married to behavioral health, to the way that we live, the way that we eat, our inability or lack of interest in physical exercise. And as a primary care provider in a rural, federally qualified health center, it would be invaluable to me to have a member of the team who could see each patient who I see, to go back and talk about better management, better self-management of their chronic condition. So last August, we are an organization under HRSA, and we had a site review in August where they came, and in those site reviews, they take a long look under the covers, and we go through all of our programs and how we're doing business. And it's a really welcome opportunity because it makes us stop and think about things that we could be doing better. And this issue of integrated behavioral health came up as one of our big black eyes. And one of the things that happened is they mentioned that we did not have, or we hadn't yet taken advantage of, using an integrated healthcare provider who could see patients every time we saw them in the office. Well, what we realized after taking these recommendations is that Medicaid in West Virginia doesn't have those codes open to our primary care providers, so we really can't take advantage of seeing patients who are already in the office. So backing up to yesteryear, we had people in our offices who were licensed clinical social workers, we had clinical psychologists, and even had psychiatry. And what happened is, after 3 different attempts, we always ended up not in the red, but in the dark red, in being able to make those programs work. And it was largely in and around patients who were unable to keep their appointments. And so what we found is that if we could really seize the opportunity of patients who are already in the office getting care, that would really be the way to reach the greatest number of people and focus on things like tobacco abuse, obesity, and even diabetic self-management. So we're still at that point where we're having trouble figuring out how to get this program to work based on the fact that we don't have the codes open in order to do it. But the reason I'm pausing here on this slide is because really those issues that I just addressed all come back to this issue of inappropriate or ineffective patterns of healthcare utilization. We are in the communities where these patients are. We have the carrot, essentially, because they are already seeking care for their chronic conditions, and it would be terrific if we could piggyback behavioral health on those visits when the patients were already in the office. So barriers to care. These are probably not unique to West Virginia and probably are unique to but also ubiquitous throughout rural settings. Number one, access. And that's really a workforce issue. In the previous presentation, we heard about these teams that were developed that involve nurse practitioners and community health workers and specialists. And one of our real issues in West Virginia is not having enough people available to see these patients. So it's just simply a supply and demand issue. Another is provider availability, and what I mean by that is so many of our specialists are tied up with our incredibly sick, acutely ill patients that those patients who really need lifestyle modifications, they're considered sort of low men on the totem pole as it relates to the priority that they take, yet it's really stopping those illnesses that it's going to create less burden on the overall healthcare system in years to come. Inpatient access is a big problem. Getting people in for inpatient therapy, whether it's drug and alcohol rehabilitation or for psychiatric care. We have a limited number of beds available for our patients. ER overutilization is another big problem. It's multifactorial. One, it's a healthcare utilization issue because of the high cost associated with ER visits. Two is the medically homeless patients, those patients who don't yet have a primary care provider, who are showing up in our emergency rooms, who are clearly behavioral health care need patients, who then are discharged from our emergency rooms and not then reconnected back into a medical home for further care. The next is codes, as I mentioned, and what I mean by that is CPT codes, ICD-9 codes, allowing those CPT codes to support a system that would allow us to keep patients in a primary care setting, which is really a segue right into the next bullet point, which is same-day visits, and figuring out a way that we can have a team member who could be doing quick, brief interventions with patients so that it wouldn't be a big bottleneck from a patient standpoint, but would also be effective because they would have multiple opportunities to outreach these patients who often tend not to show up for these visits and follow-up. And then finally, telemedicine. Telemedicine is somewhat new to West Virginia, not universally, but we're using telemedicine for teledieticians, and we've just begun to start to use a program for telebehavioral health, but nothing as robust as Project ECHO, but I do think there's tremendous opportunity for a place that is rural with such rugged geography like West Virginia has. Okay, so I want to move just very briefly into this topic of prescription drug abuse and the pain epidemic. If you look at this slide, the number of drug overdose deaths, a majority of which are from prescription drugs, in West Virginia increased by 605% since 1999 when the rate was 4.1 per 100,000. Nationally, rates have doubled in 29 states since 1999 and quadrupled in 4 of these states and tripled in more than 10. So we have a real problem with prescription drug abuse, and one of the things that we've done from an integrated behavioral health standpoint, our community health center with its 13 locations hired a specialist who is a addictions medicine board certified anesthetist. And he is working only in our outpatient setting, and all of our providers, all 50 of the people who are seeing patients out in our 9 counties in our various communities, are sending our patients who have chronic pain and who either are currently on narcotic medication or who are requesting to be placed on these medications. They all are sent to the central office where they're seen by our specialists, but equally importantly are seen by a behavioral health specialist, counselor, and we have an expert tool, this screening and brief intervention tool that allows us to identify the comorbidities that really are so closely married to chronic pain and to this problem of prescription drug abuse. Very rarely do we see a patient who has chronic pain who doesn't also have overwhelming life stressors, other chronic conditions, depression, those sorts of things. So often these patients have somatic pain, meaning pain that is really often has a psychiatric component to it, and treating their behavioral health needs and their lifestyle management often puts them in a position to feel empowered to wean themselves off of these medications. So for us, our biggest challenge has been, okay, we feel like we've done a really good job with treating patients who have been identified as pain medication seekers or legitimate chronic pain patients, because part of having access to that treatment for us has been through this path that weaves in behavioral health. But I go back to our patients who are just simply what we see very often in West Virginia, our obese, hypertension, diabetic patients who also have hyperlipidemia. And those patients who so sincerely need lifestyle modification and who need help with managing their condition and not really receiving the amount of help that they need in the office setting. This slide I wouldn't expect you to be able to read, but I just wanted to point out that this is from SAMHSA, and you can see in this, unfortunately, small font where it says state, West Virginia, July, and this is of 2014. And the important point is this box, and I'll move over next to show it, which essentially says, for federally qualified health centers, the West Virginia DHHR, Bureau for Medical Services, is currently updating its SQHC and then RHC as Rural Health Clinic, Chapter 522, blah, blah, blah. The point is, we're still stuck. And we're stuck in that we can't yet see these patients in our practice using the codes that doesn't then place a transportation barrier for these patients so that they can really get holistic care every time they're already accessing care in our medical home. So really, I just would be happy to answer questions, and I would also invite the opportunity to have anyone email either within West Virginia or outside the state if you have any innovative projects that work in a rural setting, because I would love to tell you that we had this figured out, but we just feel like we are in the beginning phases of moving down a path of getting people to understand how important this project is. So thank you very much.
Great, thank you. And thank you to both of our speakers for their excellent presentations. I would like to now open up the floor for participants' questions. As a quick reminder, to ask a question, please use the chat box in the bottom left. And we will go ahead and get started. The first question is for Miriam. Miriam, can you talk a little bit about how Project ECHO is funded, and then any payment structures for both patients and the primary care doctors using?
Sure. So the short answer is that ECHO is not really funded. The ECHO Institute here at UNM is grant funded and gets some money from the state. State Medicaid does flow through some dollars to us, but it's not on a per services basis, and it's to support the teaching that we do throughout the state and clinical support. We are working with CMS to look at opportunities for providers who participate in ECHO to bill for services. Right now, the only incentive for PCPs outside of their increase in learning and improved ability to provide care is that they do get free continuing medical education and CEU credits. At ECHO, we don't charge for our services. As I mentioned, we're grant funded and state funded, and so we provide all of our training for free of charge to organizations that are interested in learning to use the model in order to improve access to high quality care.
Great, thank you. The next question is for Dr. Chenard. It's related to, you mentioned stress-related physical symptoms. Can you talk a little bit about how health centers can address some of those issues, some of the stress-related physical ailments?
Sure. We are patient-centered medical homes in the offices at community care, and there are very many other federally qualified health centers in our state who are also NCQA certified medical homes. Part of that has really been, over the last 4 to 5 years, we've transformed our practice into really a workflow that supports patients not only when they're in the office but outside the office. By that I mean things like giving them access to a patient portal so that they can communicate with us timely after hours without having to make phone calls, being placed on hold. They have access to their chart. We've really worked on integrating care managers, people who are, if a patient comes in for an episodic visit, they come in for, let's say, sinusitis, or they have maybe a small laceration that they need repaired. Anything that would be just for an episode of care, we are also addressing their chronic health care needs. So if a person comes in with cold symptoms, we're also saying, okay, we're going to have the doc in to see you in a minute, but in the meantime, our system is showing us that, you're due for your mammogram, you're due for your blood work because you're a diabetic. Whatever the preventive measures are that would be appropriate for their age and gender and their problem list. And so we're trying to effectively treat the patient for their entire health picture, sort of the year at a glance is what we've come to call it in the clinic, each time that they come in the office. Well, because we have those patients relying on us for so much already, most of our rural patients are under hardship that is socioeconomic, based in and around rural health issues. And because they see us as their source of, and usually sole source of care, a lot of those patients, because of their overwhelming lives, end up experiencing chronic pain. And this chronic pain, often they'll say, I have chronic low back pain. Well, they never had a back injury. It's not that they were trimming a tree and fell from the tree, or they sustain some other energy and have a true radiculopathy, but really that low back pain is just a physical manifestation of the true difficulties that they have just navigating their lives. And so while some of our primary care providers are attuned to this and feel equipped to treat it, really having people on our staff who would be either social worker, community health worker, even nurse practitioner, RN level providers who could say, okay, we can address your pain, but sort of peeling back a layer of the onion, can we go back and try to figure out how we can make life more manageable such that ultimately the pain goes away not because of prescriptions, but because we're teaching you the tools that it would take to do stress reduction. We have a yoga class at our local health department, and while that's completely unfathomable to some of our rural patients, will you be surprised at who has wandered in? So I think that really what I mean when I say this sort of life stressors is that so much of the emphasis on behavioral health care, at least in our communities, has been on real mental illness and or true chronic pain, and I think that there's a lot of gray that falls somewhere in between them.
Great, thank you. The next question is actually for both of you. I'll start with Dr. Chenard. But can you think of any major policy barriers that stop health centers from integrating more behavioral health into the primary care setting, and ways that maybe legislators could remove those barriers?
Well, going back to the issue of Medicaid, because truly what happens is in West Virginia we have such a large volume of Medicaid patients in our federally qualified health centers that if Medicaid would offer reimbursement for those same-day visits, that would allow us to have the resources to hire the staff to see these patients who are already in our offices. So it's not as much a statewide policy barrier as it is a state Medicaid barrier. And I don't mean to be overly critical. I think that they, as I showed you on that slide, are actively working on this. But it would be offering the care in the places that the patients already have no transportation barriers, a level of trust that's already been developed, and a community who understands the lack of resources outside of our walls, and so figuring out a way to bring that in that's sustainable. I mean, the fact that we discussed Project ECHO as such a great concept, being that it's grant supported, I mean, for West Virginia, a project like that would really have to have statewide buy-in such that we could figure out a way to create a reimbursement structure so that we could sustain it. So that would be the biggest help for us.
Yeah, and this is Miriam Kamarami. I just wanted to second what Dr. Chenard was saying about the ability to bill for behavioral health services as a same-day visit, I think, is very key. I also think that paying based on outcomes instead of on a per-visit basis is going to get us there in terms of integrated behavioral health care and addiction treatment, because once you start looking at overall outcomes and seeing the tremendously deleterious effect that mental illness and addiction have on physical health, and it'll really force healthcare systems to tie it all together and really invest in treatment of mental health and addiction problems.
Great, thank you. I think we have time for one more question. Hold on one second. We're having a question come in on the... So this question is related to funding. Since Project ECHO is funded through grants, and you mentioned that some of the health center work would also need to be supported by grants, besides Medicaid, is there other long-term sustainable funding sources for this type of work?
Sure. I mentioned a few states that are actually implementing this at a statewide level. So Colorado is actually, several states are requiring that Medicaid recipients have some participation in an ECHO model in their state and are using Medicaid dollars to support some of this work. It actually doesn't cost a great deal to set up an ECHO network. It just is a few hours of provider time, and we use a free secure video platform that Project ECHO here in New Mexico has a license to, that we provide free of charge to collaborators who want to do this work as well. So it ends up not being a very expensive project, and if health centers choose to prioritize this, they can free up a relatively small amount of their providers' time, a lunch hour plus one additional hour out of the week, for instance. And in return, the provider gets free CME, and the community health center gets access to a provider who has updated information and additional coaching and training to treat some conditions that are, maybe very high need in that community. So I think there are creative ways of looking at this from a state level through legislative funding or working with Medicaid, as well as grant funding, which is fairly readily available right now for this model, that can help people to give this a try. We're happy to advise and collaborate with people around finding funding, and we do offer free day-long monthly ECHO orientation training. So if anybody's interested, we'd love to have you come spend some time with us here in New Mexico or participate in one of our online orientation sessions so we can help you strategize about how you might implement something like this in your locale.
Great, thank you. Dr. Chenard, did you have anything to add about sustainable funding for integration in some of these programs?
I think that one of the things that would be helpful is, as we move into this new payment methodology with Medicare, where they've implemented this MIPS, merit-based incentive program, one of the things that we could really think about moving forward is there a way for me to bring a patient into my office, allow that patient to connect with a behavioral health specialist in a distant location, and make it such that I could tie that to a visit, a primary care visit with me, that could then bleed into a specialty visit with them. Telehealth codes are kind of funny. And so there are things like the source site connection fees that are very low reimbursement, $10 or something. And then the specialist visit is charged but at a slightly lower rate. And I would argue that there is real potential for a model that would have a patient who comes in to see me. I'm treating their hypertension, their diabetes, etc. And if this is a patient who truly needs specialty care, something beyond having a in-house counselor, that patient could move right to the next exam room, with my introduction, and then move into a telehealth visit with a specialist who might be in a remote location, and it be paid just exactly like it would an office visit if they had shown up. So I think there are a lot of technicalities in and around telemedicine that make it difficult, and so really trying to ease up on the way that it must be delivered in order for it to be paid for through traditional billing is a real opportunity for growth of a program like this.
Great. Thank you very much. And again, I would like to thank today's speakers and all of the attendees for taking the time to participate in our webinar. Again, an audio conference, an audio archive of the webinar will be available on NCSL's website, as well as additional resources and papers on this topic. So we encourage you to come back to NCSL's website and share it with colleagues of interest. And with that, I will say thank you, and we will close the webinar.